Now we'll talk about medical and surgical issues in pregnancy. The first topic we're talking is hyperemesis gravidarum. This hyperemesis gravidarum is basically because of the increased beta HCG that happens in pregnancy. There is also another element that is called progesterone, which can cause hyperemesis gravidarum. The most important symptom the beta HCG produces is nausea, and whereas the progesterone is responsible for vomiting. Why is progesterone responsible for vomiting? Because it relaxes the lower esophageal sphincter, thereby delaying the gastric emptying and also causes vomiting. What is the most important risk factor for hyperemesis gravidarum? Obviously, it is the previous history of or past history of hyperemesis gravidarum. If there is increased content of beta HCG, that causes hyperemesis gravidarum. So what is the reason that causes increased beta HCG? It is hydatidiform mole, it is twin pregnancy, and if there is history of previous esophageal reflux, that can also cause hyperemesis gravidarum. Remember, most of the times hyperemesis gravidarum presents in the first trimester and usually resolves by 16 to 20 weeks of gestation. This hyperemesis gravidarum basically causes nausea and vomiting. So most of the symptoms are because of the dehydration or patient has got decreased glucose. So there can be dry mucous membrane. Patient can develop signs of tachycardia such as decreased capillary refill time and tachycardia. There can be hypoglycemia as well in hyperemesis gravidarum. Because of this hypoglycemia, patient forms ketonuria. Alright, if there is ketonuria or if there is ketonemia, you will have to admit the patient. This is the rule of USMLE step 2. Patient, because of the dehydration, can present with orthostatic hypotension. There is a lot of vomiting going on. There is a lot of emesis going on. So there can be electrolyte disturbances such as hypokalemia as well. Given that the patient has got dehydration, patient can present with decreased weight as well. So what is the baseline metabolic abnormality you will find? There will be hypokalemia. So patient presents with hypokalemic, hypochloremic, metabolic alkalosis, because there will be potassium loss, there will be HCl loss. So that leads to alkalosis and that leads to hypochloremic metabolic alkalosis. Alright, in severe cases, there can be liver injury as well, which can lead to increased AST. Alright, given that the patient has got increased beta HCG in hyperemesis gravidarum, which can cause increase in the TSH stimulation, so the patient can present with hyperthyroid symptoms as well. One most important thing you will have to remember is which of the following is a protective factor. It is tobacco use. We do not know how tobacco use promotes the protection of the patients to hyperemesis gravidarum, but there is a theory saying that it increases the metabolism of estrogen, which can cause decrease in the serum estrogen, and thereby hyperemesis gravidarum is decreased. But I'm not quite satisfied with that theory. But please do remember, beta HCG increases hyperemesis gravidarum. This is what you'll have to remember, please. Please do make sure that if the patient has got severe hyperemesis gravidarum, you will have to admit the patient to the hospital and then give antiemetics and IV fluids, please. Next, we talk about Wernicke's encephalopathy because of hyperemesis gravidarum. Whenever there is Wernicke's encephalopathy, I want you to understand that patient can present with thiamine deficiency and patient can also present with altered mental status and gait ataxia. There can be nystagmus as well. So this is what you'll have to remember. Again, patient presenting with Wernicke's encephalopathy in hyperemesis gravidarum, patient can be having the similar metabolic features such as hypochloremic metabolic alkalosis or hypokalemia or hypoglycemia, raised serum transaminases, ketonuria as well. What is the most important thing you will have to do? Please do make sure that whenever you are doing thiamine, you will have to make sure that thiamine is given to the patient before correcting the glucose in patients with Wernicke's encephalopathy. Alright, this is what you'll have to remember. We'll see the next topic. Anemia in pregnancy. Whenever there is anemia in pregnancy, it is the values that you will need to remember. Anemia in pregnancy is defined if the patient has got a decreased hemoglobin, that is less than 11 gram per deciliter in first and third trimester, and if it is less than 10.5 gram per deciliter in second trimester, it is considered as anemia in pregnancy. Most of the times it is the iron deficiency anemia that is usually seen in pregnancy, where ferritin is less than 30 microgram per deciliter. So please do consider oral iron first, and if the patient is not responding, you will have to consider parenteral iron. There is this famous question, inflammatory bowel disease, patient getting pregnant and there is anemia, what do you have to do? Do not go for oral iron. It is the parenteral iron that you will have to consider, please. Next, we talk about thrombocytopenias. There is a long list of thrombocytopenia that you will have to consider. But the most important thing is a gestational thrombocytopenia, where the patient is asymptomatic, but there can be thrombocyte level of 100 to 150,000. Next, we talk about thrombotic thrombocytopenic purpura. Whenever there is thrombotic thrombocytopenic purpura in obstetrics, you will have to understand that patient has got thrombocytopenia of less than 30,000, and there can be neurological symptoms associated with pain. But remember, there will be normal APTT and normal PT in thrombotic thrombocytopenic purpura. The same is for immune mediated, that is ITP, immune mediated thrombocytopenia. But remember, the patients are usually asymptomatic without any symptoms when compared to thrombotic thrombocytopenic purpura. Immune mediated thrombocytopenia usually has got less than 1 lakh thrombocytes, not 30,000. Alright, thrombocytopenia in pregnancy, you will have to consider preeclampsia as well, because there is this feature called HELP syndrome, where there is hemolysis, elevated liver enzymes and low platelet count, which is suggestive of severe preeclampsia, please. Alright. Examiner can also talk to you about heparin-induced thrombocytopenia in patients who have received heparin as well. So please do remember that. Patient can also talk about bleeding from the IV cannula site, where the examiner wants you to understand that it is disseminated intravascular coagulopathy with raised PT and raised APTT as well. Alright. Next, we talk about gestational diabetes mellitus. I want you to understand that gestational diabetes mellitus is basically because of the human placental lactogen that is being secreted around 24 to 28 weeks of gestation, which increases it. So you will have to monitor or screen the patient for gestational diabetes at 24 to 28 weeks of gestation. This is the first most important step you will have to remember. How do you screen the patients? It is by 1 hour glucose challenge test, or it is basically the 3-hour glucose tolerance test that you will have to consider. Examiner is interested about the management. The first management is diet. Second management is considered insulin release. What is the target blood glucose? You will have to consider. If it is fasting, it is less than 95 milligram per deciliter. If the patient has got a first hour postprandial, it is less than 140, we will have to aim. If it is second hourly, it is less than 120, that you will have to aim for the target blood pressure. How do you consider the postpartum management of gestational diabetes mellitus? It is basically fasting blood glucose that is done at 24 to 72 hours, and second hourly it is 75 grams of glucose tolerance test that you will have to consider at 6 to 12 weeks of gestation, 6 to 12 weeks of postpartum. This is how you will have to consider postpartum management. I'll repeat this again because this was recently asked. You will have to check the fasting glucose at 24 to 72 hours, that is 1 to 3 days you will have to check for fasting blood glucose, and then you will have to consider a glucose tolerance test at 6 to 12 weeks of postpartum. This is how you will have to follow up the patient with gestational diabetes mellitus in pregnancy. Remember, why are we monitoring the patients with gestational diabetes mellitus? Because they are at risk of developing type 2 diabetes mellitus. Alright. Next, we talk about intrahepatic cholestasis of pregnancy. If the patient has got increased total bile acids of more than 10 micromole per liter, it is intrahepatic cholestasis of pregnancy. The first most important risk factor is prior intrahepatic cholestasis of pregnancy. Obviously, advanced age and multiple pregnancies can also cause intrahepatic cholestasis pregnancy, but please do remember that prior intrahepatic cholestasis of pregnancy is the most important thing. The examiner will classically tell you in the question that patient has got pruritus, that is worse on palm and soles with increased bile acids. Sometimes there can be elevated aminotransferases as well. Alright, so you will have to consider the treatment with ursodiol or ursodeoxycholic acid is what you will have to find. Why are we treating intrahepatic cholestasis of pregnancy? Because the patient are at increased risk of complications where there can be fetal demise or there can be preterm delivery as well. There is meconium stained amniotic fluid that can happen in intrahepatic cholestasis of pregnancy. Most of the patients after birth die because patient has got or the fetus has got neonatal respiratory distress syndrome. Alright. So, four most important complications. One is preterm delivery. That is why you will have to treat the patients with intrahepatic cholestasis of pregnancy. Next, intrauterine fetal demise can be a problem. Third one is meconium stained amniotic fluid can be seen and patients usually die of neonatal respiratory distress syndrome. These are the things you will have to remember, please. Next, we talk about appendicitis in pregnancy. Whenever there is appendicitis question, you will have to consider that the patient has got right upper quadrant pain, please. If there is right upper quadrant pain, sudden onset, you will have to think of appendicitis in pregnancy. Obviously, the patient can present with nausea, vomiting, anorexia. There can be fever, raised leukocytes, and there can be point tenderness as well. So, you will have to treat the patients with surgery. Please do not delay because there can be increased risk of perforation as well. It is the diagnosis that you will have to do in patients with pregnant patient with appendicitis. All right. Next, we talk about DVT and pulmonary embolism. Obviously, patient who are pregnant has got increased pregnancy is a hypercoagulable state, so there will be increased DVT or pulmonary embolism formation as well. So the risk increases almost up to 5 times. Please do remember that warfarin is contraindicated. This is the question here because there is this syndrome called contrary syndrome which can develop with warfarin use. So you will have to use low molecular weight heparin until 6 weeks postpartum, please. All right. The symptoms are safe. The symptoms are same in normal and in pregnant. It is the low molecular weight heparin that you will have to give in pregnant patients and not warfarin. This is one thing you will have to remember. Next, we talk about bipolar disorder management. Whenever there is bipolar disorder management, the treatment is very important because valproate is contraindicated in pregnancy. Whenever there is valproate that is contraindicated, the next best step is lamotrigine that needs to be given. We all know that lithium can be used in normal patients, but lithium causes Epstein anomaly. So lithium and valproate are contraindicated in pregnancy, and it is the lamotrigine that needs to be given in patient who has got bipolar disorder, please. All right. Next, we talk about sickle cell anemia and patient who has got pregnancy. Remember, whenever there is sickle cell disease in pregnant patients, the most important thing the examiner asks you is an acute painful episode because it increases the metabolic demand, because it is a painful crisis, it is a vaso-occlusive crisis. So you will have to treat this patient. How do you treat this patient? It is basically by the IV fluids. Patient needs to be given proper pain medications. Patient needs to be given blood transfusion as well. All right. Why are we treating patients with sickle cell disease? Because there can be increased risk of abruptio placenta. There can be preeclampsia or eclampsia that can be happening, or patient can develop spontaneous abortion as well. This is what you will have to consider in patients with sickle cell disease. All right. Next, we talk about the infectious disorders and immunizations. I'll see you in the next session. Thank you very much.